Yeah, I think Jignesh, who has joined? I think Dr. Arvind Kumar has joined. Then,
Yeah.
yes, sir. Good afternoon, sir. I think, yeah, can you listen?
Okay. Am I audible to you?
Yeah. Very, yeah, clear, sir. Clear from your side.
So we are ready from our side.
Yeah. So I think, sir, what will be the flow? Initial, just I'll give you introduction. I have your CV slide, and
Okay.
after that, just you will set the context of
બંધ
today's
થઈ ગયું,
meeting.
લાઈવ ચાલુ થઈ ગયું, Zydus amlodac.
Okay, sir. And then, sir, you will introduce both the speakers, Dr. P. Manokar first, and then
હા.
Dr. Anand Kumar. And
Okay.
after that, they will present their session for 10 to 15 minutes. And after that, sir, you will
But
take
sir,
moderation and panel discussion.
Okay. Just can you show me the CV of both Manohar and Anand Kumar, any slide or something like that, so that I can read through and
Sir, it is there on my screen.
બતાવે.
Once your introduction will be over, now, sir, automatically that slide will come.
Okay.
Sure, I will change it
કાંઈ
from
વાંધો
my
નહીં,
end.
હારું છે, ક્યારેક તો ખબર.
Okay, sir.
Okay.
કાંઈ વાંધો નહીં.
Yeah. I think Jignesh, તમારો voice આવે છે અહીંયા. Your voice is coming. So, sir, I think we'll start net by almost in next 15 minutes. We'll start. Okay. And we are just waiting to be joining from Dr. Anand Kumar and Dr. P. Manokar. So they will also join in recent time. I think they must be joining in next 5 minutes.
Paper pen.
તમે મીટિંગ આઈડી આમાં નથી નાખવાનું. એક મિનિટ, તમે કઈ લિંક ઓપન કરી? નહીં, ઝૂમમાં નહીં, પેલી મેં તમને લિંક મોકલી ને, એ ડાયરેક્ટ ઓપન કરો ને. આવી અને amlodac પાસવર્ડ. બરાબર. હા, મિસ્ટર અહીંયા છે ને, એને તમારું નામ નાખી દો, ડૉક્ટર મયંક.
ચાલુ નથી થયું.
ના, તમારું મેઇન આઈડી. મોબાઈલ નંબર શું છે?
કોઈનો આવશે
ના
નહીં.
हेलो आनंद सर, कुणाल सर, आनंद सर ज्वाइन हो चुके हैं। कुणाल सर, sir, there is some problem with you.
Now, can you listen me?
Yes, sir.
Okay, fine. Good evening, Doctor.
Good evening, Kunal. Good evening. How are you?
Kunal sir, there is, I think, some voices coming from your side.
Just hold on. Now,
Now it's okay. Now it's coming.
just hold on.
Dr. Manoharan, good afternoon. Good evening.
Kunal sir, don't use headphone. I think there is a problem with the headphone.
So now it's okay.
Yeah, sir. Now it's okay.
Yeah, there was a voice from off the.
Sir, currently it's coming.
Still, it's coming. बहुत ज़्यादा आ रहा है क्या?
बहुत ही ज़्यादा और कुछ सुनाई नहीं देता.
And now?
Now it's not coming.
Okay. It's okay now?
It's okay now.
Okay, fine.
Kunal sir, Anand sir is there.
Yeah. So.
Yeah. Good afternoon, Dr. Manoharan also.
Yeah.
I just want to know about this sequence. You will be introducing Mr. Kunal? Or?
Yes, sir. What I'll do first, I'll introduce Dr. Arvind Kumar, who is a moderator for today's session.
Okay.
And after that, sir, he will introduce both the speakers. First, Dr. P. Manokar, and then you. And sir, then presentation will be started. So first session will be on this ACS management.
Sir, Manokar sir will also join it.
Yeah.
Manokar sir, can you start your camera and mic?
Just sir, so the sequence will be the first presentation by Dr. P. Manokar, and after that, sir, there will be your presentation on
Dr. Manohar is mainly Manohar is mainly speaking on ACS.
Yeah, ACS in COVID-19 scenario, and sir, your presentation
I will be speaking on myocarditis.
Related myocarditis and shortness of breath in COVID-19 scenario, sir.
Yes.
Okay.
Yeah. Good afternoon, Dr. Manokar, sir.
Good afternoon, Kunal.
Yes, sir.
Dr. Manohar, good afternoon. This is Dr. Anand.
How are you, sir?
Fine. I'm just starting.
Sure, sir.
Yeah. Hello.
Hello, sir.
Yeah. So I think, sir, I just request both the speakers, sir. You have on the bottom of your screen there is a share button is there. So when your turn is coming, sir, you just click on that share button so that your presentation will be, shown to the entire audience.
Kunal, don't worry. We are doing daily 5 Zoom sessions.
That is good.
We have all become Zoom experts now. We are suffering from hyper Zoomosis.
Yeah. That is also right, sir.
Yes, sure.
Okay, so sir, in
discussion is after the two speeches or in between?
Yes, sir. After two presentation, Dr. Anand Kumar will take a session. Will take the moderation and panel discussion.
Okay, thanks.
And in between, I will share the questions from the audience also as well. So there will be more discussion will be on that part.
Okay, fine.
Yeah. So, sir, still we have 4 minutes left. Exact by 5, sir, we'll start.
Sure.
Get the CV of Dr. Manohar and Dr. Anand.
Yes, sir, that is there along with me. Okay, and I will share the screen from here, so you will able to see definitely.
Okay.
Yeah. Okay.
Kunal sir, we are about to go. Kunal sir,
Hello. Mr. Kunal, the video, the presentation, can I do from my laptop?
Yeah, definitely, sir. You can do
Fine,
that. Yeah,
fine.
yeah,
Thank you.
definitely.
Thank you.
Yes, sir, I think just in 1 minute, sir, we can start. 5, sure. Okay, then I think shall we start?
Yes, we can
Yeah,
start.
yeah,
Yeah.
yeah.
So very good evening, all respected. I hope you all are well and healthy at your places, because in current scenario of COVID-19, this is one of the best tool, and actually, in fact, it is a boon for us to disseminate the scientific data in medical fraternity, that this digital media. So with this positive note, I am Dr. Kunal from Zydus Medical Team, and I would like to do warm welcome of each one of you on this scientific webinar titled as a reliable talk. In this webinars, we have planned the two presentations considering in current scenario of COVID-19. One presentation will be on the management of acute coronary syndrome cases, and the second will be on the when patient come in with the symptoms of dyspnea and shortness of breath. In that cases, how to deal with that. So before starting a session here, I would like to uh, introduce our moderator for the today's session. So I'll just introduce them. So here I would like to introduce our moderator, Dr. Arvind Kumar, who is a chief cardiologist and interventional cardiologist from Kaveri Heart Center, Trichy. He has been participated in various clinical trials and having a vast clinical experience and achievement in the cardiology therapy area with more than 300 angioplasties. And he is very well expert in organizing many scientific activities, workshops, and all the academic activities as well. And he is associated as a member of many national and international organizations. So without taking much time, I would like to request Dr. Arun Kumar. Sir, first you may introduce our both the speakers, and after that, Dr. P. Manokar will take his first session, and followed by Dr. Anand Kumar will take a session. So, sir, the screen now over to you. Thank you.
Thank you, Dr. Kunal. I believe I am Dr. Arvind Kumar from Trichy. I believe I am the only person in hospital now, because I am in the hospital boardroom and rest of the people are in his respective house, I believe. It's warm welcome to everybody. Good evening, friends. This is Dr. Arvind Kumar again. I want to introduce Dr. Manokar and Dr. Anand Kumar here. Just can I have the slide so that I can
Yes, sir.
introduce Dr. Manokar now?
Sure. Yeah. Yes, sir.
Dr. Manohar is one of wonderful interventional cardiologists from Ramachandra Medical University, Chennai. And I know him personally, and he has been an invited faculty in various national and international conferences and has received a esteemed APJ Abdul Kalam Excellency Award in 2017. And you know that he is an expertise in interventional cardiology, and most of his postings and references and the expert opinion in our WhatsApp forum enlightens most of us. And he is also associated with multiple social work and public awareness program. And he'll be talking on acute coronary syndrome. And before going to him, I'll introduce the other speaker also, so that they can have a continuous talk over the next 20 minutes. And we have another speaker, Dr. Anand Kumar. He is from Cochin. He did the first across joint peripheral angioplasty in South India using flexible stent technology. And it's going to be tough reading itself. I just amazed how these people are doing all these things. Started the first advanced hypertension clinic in Kerala in 2006 and served as a principal investigator for over 10 multinational, multicentric clinical trials. So with this vast experience speakers, we'll be joining Dr. Manogar in talking about the acute coronary syndrome in managing coronary disease at this current scenario of COVID situation. Before going into Dr. Manogar, I'll just put forth my views, one just for 30 seconds or so. So today I had a tough day in office. In fact, I had 3 angioplasties, which I do not know whether I am correct or not, because including a 85-year-old guy who underwent an angioplasty today morning with me. So this is the scenario where we do not know whether we are dealing it correctly or not. We don't have real clear protocol, and we lot of COVID mimickers are there with an acute coronary syndrome overlapping it. Just enlighten us on for the next 20 to 10 minutes or so that we can have some crystal clear idea of what we are, how we are dealing. Over to Dr. Manohar, sir.
Good evening, everybody. Good evening, friends. Thanks, sir, for the kind introduction. So I would start off by sharing my presentation, and obviously the idea of this presentation is to make sure that we have more elaborate discussion. So I'll keep myself restricted to what everybody says. So because Dr. Arvind sir shared that he did 3 PTCS today. In the last 30 days, I have not done a single PTCA. So I'm talking all theory, no practical, because I have restricted myself to giving Zoom seminars for the last 30 days. So let us discuss what things have developed and what new things we are knowing since the evolution of this COVID, this thing. So to cut things short, instead of talking ACS, we'll directly jump to ACS in the COVID era. So one interesting thing that has happened in the last a few weeks or few months, you would like to say, is that people have started thinking that the MIs have actually reduced. In fact, one of my senior colleagues keeps telling that actually speaking, the MIs have reduced. It is you and I refuse to accept it. That is his take on the whole issue. So he strongly believes that the MIs have genuinely reduced. But it is not only his concern. In fact, many other people have the same concern. So many people sincerely believe that the MIs have reduced, and kind of there has been a change in the pattern of the presentation. I'm sorry, my just give me a moment. Yes, I'll go back to that slide. Yes. So the TCT was very there was a very interesting article, and everybody feels that MIs are reduced. So unlike Dr. Arvind Kumar, we are actually unemployed, or in other words, we are partially employed or without job. And the biggest feeling is this is because there is a big fear of infection. And although there are many people telling that no, people are taking rest at home, nobody is smoking, nobody is drinking, the stress levels are less, so many explanations are there. But it is difficult for us to believe that MIs have reduced, because traditionally we have not experienced influenza epidemics in our country. But even in the West, usually when the influenza levels drop, that is as the winter goes away, the MIs actually peak. So even from that context, it is very difficult to explain the mystery of the missing ST elevation MIs. So this is a very big challenge. Maybe 1 year, 2 years from now, we will have a lot of papers as to what happened. Did people drop dead at home, or something else happened, or in some way COVID protected from a ST elevation MI? That is for a debate and for a discussion at a later date. But across the world, everybody, not just me or my colleague, everybody feels that people are so terrified at home that they are not showing up in the emergency department, which are in itself totally collapsed. Somebody mentioned that the every day they have 3 MIs in the night, and coincidentally for the last 3 days they didn't have a single MI. So this is that gist of that article, that if we have been having a weird month actually, that genuinely patients are afraid that if they come to the hospital, the only gift that we can give them is COVID-19. So despite this good news that actually ACS is less, let us assume what the general advice is. So whatever I am sharing is all theoretical knowledge. The Chinese people, obviously, they suffered the maximum impact of the COVID-19 in the beginning of this year. So they were the first to come out with this article, which was published in the European Society of Cardiology, and the recommendations from the Peking Union Medical College Hospital, and they were very blunt. The Chinese advice was really blunt, and although this is a very busy slide, but the simple thinking was that at the beginning itself, they're telling you think of alternative causes of ST segment elevation. So Dr. Arvind pointed out he himself was not sure about those COVID mimickers. So this is something very important. Although you think it is ST elevation MI, please think of alternative causes of ST elevation MI, although the ECG is clear cut ST elevation MI. So
Yes, Dr.
the first advice is uh, uh, get that patient evaluated by a senior person. Make sure that it is ST elevation. If it is not, you are convinced that there is no other cause, then think whether it is less than 12 hours, then consider whether there is a contraindication to thrombolysis. If not, go ahead and thrombolize. Once thrombolysis is successful, then shift the patient to a COVID screening procedure, evaluate the risk of COVID infection, yes or no, and then if it is no, then treat it for CCU for further evaluation. If it is yes, go for a laboratory test, and if negative, then shift patient to the cancer designated medical institution for COVID infection. To put it in simple words, there is no mention about primary PCI in this whole chart. That means for a suspected ST elevation MI, the Chinese are very clear. Please don't take the patient to the cath lab. Please don't take. The same thing applies to NST elevation MI. Although it's a busy slide, here the only difference is even before thrombolytic, even before initiation of medical therapy, they ask you to screen for whether it is a high risk NSTMI or a low risk, and to look at the potential risk of COVID infection. But the bottom line I want to stress upon is the Chinese are very clear. Don't take people to the cath lab. As simple as that. Now, obviously, if the Chinese give some advice, just like Donald Trump likes to add his component, the Americans also join. And the April 9th, there was a very nice article in the ACC, and he mentioned about all the controversies in managing acute MI. And they stressed on a lot of advices. But the key points I have enumerated, everybody is very clear. Imagine from 1996 to 2020, everybody said primary PCI is the first choice in acute coronary syndrome in acute ST elevation MI. And now ACC says emergency IV thrombolysis is the first choice. And that ends it, period. That ends all debates, discussion about what is good. So thrombolytic therapy is the first choice in these patients, and that's the first message I want to clearly convey to each people in this audience, that emergency thrombolytic therapy is the option number one. Once patients thrombolytic therapy has been taken care of, then COVID could be excluded. Then you closely monitor and then consider for emergency after eliminating COVID. That means if you are suspecting COVID, please do not jump to get patients to the cath lab unless you are excluding COVID in the patient. So even for failed thrombolysis, even for other situations, if you think that the vessel is not recanalized, perform CT chest. See, this is a very important advice. No other guidelines mentions this. The Americans were the first to say that send patients for CT angiogram, but not cath lab. CT angiogram, check the you look at it, check the recanalization status. You look at the middle of the slide, check the recanalization status of the myocardial, perform CT immediately. So they are not advising you to take patient to cath lab even after thrombolysis, even if you suspect it is a failed thrombolysis. And that's a very important point to note. In fact, they have been very strongly promoting to do a CT test on a regular basis, so that patients with thrombolytic therapy, we can clearly pick up the incidence of COVID in these patients and take it forward from there. So that's a very important advice, that if there is any doubt, please send the patient to CT. Ask the guy to look at CT lung, ask the guy to do a CT coronary also. So, but not a conventional cath lab procedure. That's the point which has been very aggressively emphasized. What about PTCA? Very simple advice. PCA should be but for only culprit vessel. Try to avoid intubation. Try to avoid intubation. If CPR is required, try using. We don't have that in our country, but that's what they are advising. If you have any suspicion, please intubate them in the ICU. Not early intubation should be considered to prevent aerosolization. So please avoid intubation in the cath lab. So that's the second message that they want to give you. Since the ACC gave some advice, the Sky also had to give its piece of advice. Again, an American body, and one of the it got published in the Journal of American College of Cardiology, and this is an elaborate procedure. So why I put up this is you have to understand that just look at the number of steps they have mentioned. It will take 2 minutes for you to do it. And the last thing to remove is your lead apron, over which the surgical scrub, head cover, N95. Uh, see the look, see the steps. So this is a doffing and this is donning. So again, the slides are in reverse order, but when you put up, this is what is advised. So 2 pairs of gowns, 2 pairs of gloves, eye protection, hand hygiene, surgical mask, second head cover, first head cover, N95 mask. So these things, please understand before even considering a patient for intervention. So what I liked in the Sky guidelines is there are 2-3 good things that they have mentioned. So how to plan an intervention. So for example, in a busy hospital like Dr. Kaveri Hospital or my own institution, how they have planned is, so one intervention cardiologist will be attending for daytime cases from Monday to Thursday. The one IC intervention cardiologist will be attending as backup for daytime, and the other attending as available, and rotate primary and secondary IC in successive weeks. The concept is very simple. The cases are very less. So even if you require it, this is the protocol. Weekend and weekend calls will be the same. And very nice advice, but very practical advice. Then how to have this model. So one attending, one fellow, 2 nurses, not more than that. Try to limit the number of people in the team. Try to make sure this team stays together. Unless someone requests quarantine, at which one point the whole team is out until the quarantine is lifted. If one person in the team is affected, the whole team goes out. The Monday to Thursday, two teams working during the day, separate team on call at night. Friday and Sunday function as a weekend with one team on call. The concepts are very simple. Stick to your team. Try to make sure that you don't go out of the team, and make sure that these things are taken care of. Same thing, most of our hospitals do not have it, but they have advised if you have 2 cath labs, make one as a COVID cath lab. Try possible to a negative pressure things, or if it is not possible, try to consider HEPA filters. I know most of the cath labs in our country do not have HEPA filters. I do not know whether any cath lab in our country has negative pressure. So I can, please correct me if I'm wrong, but according to me, there's not a single cath lab in India which I know has a negative pressure option. That's the reason why we are so skeptical about advising intervention. They obviously, from learning from the Americans, Chinese, it should also matter that we learn from the Italians who have suffered the most. Please remember, the person who has written the article himself is a interventional cardiologist. He himself is COVID affected, and he has written this article when he is in quarantine. But the message he conveys is the same: avoid intervention at all costs. And that's a very nicely written article, but the message is loud and clear: please avoid intervention unless there is no other alternative. The British are also suffering. One of the very nice article which they have put up in circulation, more or less same things, but the concept is reperfusion. It is not business as usual. So reperfusion in the era of COVID is not business as usual. So if anybody was doing 5 PTCs a day, please understand this is not the time to do it. Please avoid it. Please skip them. And these guidelines are more or less on the same track that I mentioned about the Chinese guidelines, but they tried to include two, three extra things. So I put up this slide. It's a very busy slide, but they are trying to locate where the IRA is, whether the patient has hypotension, Phillips class, whether cardiogenic shock, delayed presentation. So all these things they are considering as a favoring intervention. On the other side, they are looking at people who are having contraindications to fibrinolytic therapy. In all these situations, they are advising these patients to consider primary PCA. Again, I'm repeating, consider primary PCA. Consider fibrinolytic therapy is coming on top, which was never the case in the past. And primary PCA, rescue PCA for failed fibrinolysis. And again, despite all these things, he's repeatedly selling, transfer to isolation ward and try to look at the COVID-19 risk. So the message is loud and clear. And to conclude, before I wind up things, the CSA has issued a very nice article recommending the way they want the statement should come with respect to the CSA. CSA introduce more or less whatever they've advised is more or less on the similar lines that what the Americans, the Sky, ACC, the British, and the European, and all the recommendations. But they introduced few things which I thought is worth sharing. That's why I put up this thing. They have mentioned that range of cardiovascular manifestations. The first thing is acute cardiac injury. So this is a very important thing, and it does not mean that patient have ST elevation always. It is a ACS picture, although type 1 ACS, that is due to atherosclerotic plaque rupture, is less uncommon. So acute cardiac injury is the first thing. Myocarditis, cytocardiomyopathy, we know all these things. In fact, my colleague in Mumbai was sharing with me that in one of the hospitals, they are routinely doing IL-6 levels. And the moment IL-6 levels goes up, they give tocilizumab to those patients, because these are the patients who are going to have myocarditis, cardiomyopathy, and eventually downhill course and they die. So one of the commonest thing that people are doing in these patients is to consider IL-6 levels on a daily basis. The next thing is look for arrhythmias, because China, they reported almost like 1/6 of the patients had significant arrhythmias. Similarly, venous thromboembolism, we all know, is a very important complication. That's why many institutions have a I'm sorry, an anticoagulation protocol specifically looking at the venous thromboembolism risk and trying to reduce it. What I liked in the CSI paper is they, unlike the other institutions, because CSI understands the trouble with checking for COVID-19 in patients. So they have said that this group A patients are patients who have a positive COVID result. Although these patients are less, but their numbers are growing, and with community spread, we expect it to be more. Group B is suspected COVID, that is, patient in the stage 2 of the epidemic spread, where there is no community spread happening, where patient gives a history of travel or a close contact is there, but still I think group B is the biggest group that we are dealing with. Group C is obviously the patients that Dr. Arvind is seeing, Arvind sir is seeing, because maybe in that area there are people without any history of travel or contact with the patient, or we have checked and COVID is negative. So this is the safest group, and based on this, they have advised to consider B and C in the same group and group A as different. Before I conclude, I know my words may not be taken in by everybody in the same spirit, but my advice would be very simple. Every patient who comes to ER is a COVID suspect, and save yourself and your staff. So somebody can talk heroically saying, no, I did a left main PTCA and blah, blah, blah things and saved the patient. We may have saved the patient, but if all your staff end up being infected and one of your staff uh, loses his life, I think we are not morally justified. In fact, you must have read the case in Chennai where the orthopedic surgeon passed away. The sad truth is the patient who was operated by the orthopedic surgeon was a COVID positive patient, and today he has recovered from it. So this can happen with you also. You end up saving somebody and losing one of your key staff members. It's not worth it. And as I put it, conservatism although is the thing I always avoid, but I would put it as the new cool of the season today. Thank you.
Thanks, Dr. Manohar. The message is strong and very clear. We can have a lot of discussion after the second presentation. I invite Dr. Anand Kumar to go with the presentation.
Sure, sir. Sure, sir.
Thank you. Good afternoon. Am I audible?
You are audible.
Yeah, thank you. Thank you.
Yes, sir.
Thank you for inviting me to this audience. And to Dr. Manohar, it was an excellent talk. I have been conducting and hearing a lot of webinars during this COVID season, and I will say that Dr. Manohar's talk was one of the best talks I have ever seen in this COVID season. He has excellently covered and made his point that how we should manage an ACS patient during this COVID scenario.
Thank
So,
you, sir. Thank you, sir.
So my few slides will be on COVID patients coming with cardiac dyspnea. So I think because most of us are in the cardiology itself in the audience, I will skip most of these initial introductory slides. Dyspnea is a very common symptom. 25% of our patients in it sometime in their life will have dyspnea, and this can be we can have our clinical as well as lab differentiation into which category of systems they belong, whether it's a respiratory, cardiovascular, neurovascular, systemic, or psychogenic. We now have excellent imaging tools like X-ray, echo, CT scan, as well as lab markers like troponin, BNP, NT-proBNP. So the management and the differentiation of dyspnea is not very difficult nowadays, even in most of the secondary and tertiary care centers. Even in the ER, we have all these facilities available. So, of course, when even in ACS, when the patient has dyspnea, it actually alters the prognosis, because you can see in this is a slide showing the survival of ACS MI patients presenting with chest pain, and if you see the prognosis of patients presenting with dyspnea, it is the mortality is almost more than 2 times higher, and at about 4 to 5 years, the mortality is almost close to 60%, which is the mortality of MI patients presenting with cardiac arrest itself. So coming to how to approach dyspnea in the current situation, whether it's obviously, as Dr. Manohar said, the guidelines are evolving and changing day by day. In a large country like ours, in fact, maybe I will see that the way different states are, the different emerging patterns of disease in different states, sometimes I feel that even a state has to be considered a separate entity, because the some states have a very high incidence, but the number of patients are coming down. On the other hand, we have patients with high incidence and going up. So the number of the 3 types of patients Dr. Manohar said, like the COVID positive patient, COVID suspected patient, and non-COVID patients, this will be constantly changing in different states, and the guidelines also has to be slightly modified according to that. So overall, I think very soon, or even now in most of the states, we have to consider a patient with dyspnea and maybe fever as a COVID patient unless proved otherwise. Of course, we now have this ICMR criteria. So these are the 3 first questions which we will ask when a patient comes with a shortness of breath, whether the patient has been to a foreign country or his family, close family has returned from a foreign country within 2 weeks. But now we are seeing in Kerala, for example, we now had a patient who was in home quarantine from Dubai, he was negative. He became positive on 38th day. So we are learning new things about this coronavirus every day. So I think at least in the last 28 days, if somebody has been out of the country or living with a family member who is out of the country, that raises a strong suspicion of, and he has to be is COVID suspected. Again, a patient who is in home quarantine, or a patient who has treated, has been in the family, or who has been in a center which is actively treating COVID patients. Again, you have to ask for fever, cough, sore throat, breathlessness. And we have ICMR is divided into 3 types, category A, B, C. And any fever or any dyspnea makes the patient in class 3. Any dyspnea makes the patient class 3, highest risk. These are something like a red flag patient. And in this high risk patient also, hypoxia, saturation less than 93%, tachycardia, heart rate more than 125, and respiratory rate more than 30, blood pressure less than 90, all should be alert the possibility of a very guarded prognosis. And of course, lab values, CRP, high CPK, ferritin levels more than 300, troponin elevation, D-dimer. D-dimer is also now coming up in a big way because microthrombosis has been a mechanism which now everybody is thinking of. So apart from lung, which has been the primary target of the coronavirus, SARS coronavirus 2, the second most common affected organ seems to be definitely the cardiovascular system. And in heart, we have been knowing that other than this acute coronary syndrome, we have myocarditis, ventricular arrhythmias, and pulmonary microthrombosis, and is coming up. And this is the case report of the first case of COVID-19 complicated fulminant myocarditis from China. It's a 63-year-old person who was admitted with pneumonia and then had cardiac symptoms. And which are the causes of this myocardial involvement or myocarditis, myocardial injury in this COVID? There are multiple mechanisms are proposed, and it is one important thing which has been shown mainly in the European subset as the elderly patients usually have a more mortality and more pneumonia, but slightly younger patients have more of this cardiac involvement, especially myocarditis, myocardial injury, LV dysfunction, and very poor prognosis. And another important thing that we should know is that this can occur even after the pneumonia phase or even after the pneumonia phase has recovered. So these two things, this thing, there are certain reports from Italy saying that the viral load may be a important factor in cardiac illness due to COVID, because this has been seen more common in healthcare professionals who are getting COVID infections, and healthcare officials, both doctors, nurses, paramedical staff treating COVID patients, they are probably receive a higher viral load, and this may also have a pathology in progressing to cardiac involvement. So mechanisms are not fully understood, but it is thought that it may be because of a cytokine storm, because this happens a slightly advanced stage, and the cytokine storm, that is interleukin mediated myocardial and conduction system injuries, and also vascular thrombosis. We have only very limited autopsy data. Only I have been seeing one group of autopsy data from USA, which has shown that even in patients with full-blown LV dysfunction, they could not reliably demonstrate viral RNA in the myocardium. So this is a very small group, only about 2 or 3 cases. So their initial findings also support that the cardiac involvement, especially myocarditis, LV dysfunction, may be more of cytokine storm related rather than a direct viral invasion of the myocardium. So this is the real life case, the first case which is given in from China. And this is a 63-year-old male admitted with the shortness of breath, expectation, fever, and no previous comorbidities. Of course, previous history of allergic cough and previous smoking history was there. And the ABG showed severe acidosis, respiratory acidosis, and low saturation 90 to less than 92%. Troponins were elevated, and there was a decrease in LV ejection fraction in echocardiography. Interleukin levels were elevated, and the X-ray and CT test was typical, showed typical interstitial viral pneumonia pattern. ECG does not show ST elevation. Maybe you can say there's some RBBB and some secondary ST changes, sinus tachycardia, some non-specific ST changes in the limb leads also. And you can see the troponins, once the patient's echo showed severe LV dysfunction later, and the troponins on treatment with ventilation significantly improved. The myoglobin levels were having on a up-down pattern, but the NT-proBNP as well as the troponin significantly improved in the next 2 weeks. This is the echocardiography showing a EF 32% and a mild pulmonary hypertension. And the patient has given ventilatory support, high flow oxygen, which was the pattern at that time, but nowadays we give a low pressure, low PEEP, high concentration oxygen. Lopinavir, ritonavir antiviral therapy, interferon alpha 1 alpha, methylprednisolone, immunoglobulin, piperacillin, tazobactam, and the renal replacement therapy. So after the treatment, LV ejection fraction improved to 68%, and left ventricular thickness, everything improved. But this patient later had probably a septic shock and disseminated intravascular coagulation. In this article also they said they are not sure whether it is secondary to, it is continuing viral infection, because viral swab later become negative, but they attribute this may be a secondary infection with the sepsis, and the patient ultimately died on 33rd day of 33rd day. So the COVID-19 can definitely present with multiple fulminant myocarditis. We have been having a lot of cases from Italy, USA. Both the countries have shown that more than the lung involvement, mortality is more common when you have a heart involvement. And heart is a secondary target after the lungs, and it is possibly immune-mediated injury rather than viral infection. And I'll skip, Treatment will be mostly supportive therapy and associated heart failure management. Anticoagulation is probably becoming important, especially with heparin-based therapies, because microthrombi has been found to be a major component of the pathology in the lungs, and this may be important in cardiac involvement also, including myocarditis also, maybe because of microthrombi at arteriolar level. Antiviral immunomodulatory therapies may not be working at this stage, because the mechanism is most likely due to cytokine storm. So monoclonal antibodies against interleukin like tocilizumab may be the answer, but we are all our suggestions are only suggestions, and everything has to be tried and verified, or we need a clinical trial. So thank you, and I think we'll have the discussions now. Thank you.
Wonderful, Dr. Anand Kumar. We are really competent with Dr. Manohar for the best presentation. Both of you have presented really well. Am I audible?
Yes, sir.
Yes, sir. You are audible, sir.
Yes.
Please go ahead.
I'll just kickstart the discussion.
Hmm.
Everybody, every delegates are allowed to start questioning, or we are the one who are going to debate it.
Yes, sir. What we can do, sir, you can start the panel discussion. I will filter out the question set from my side, and I will share with you at the end of the panel discussion. From your
Okay,
side.
fine. I'll just start the discussion by asking a question to our Manohar. Sir, are you in line?
Yes, sir.
Yes.
Yes,
Sir,
sir.
your presentation was wonderful,
Thanks, sir.
extraordinary. Say, just I'll put a simple question to you.
Sir, tell me, sir.
Most of the people we come across with the COVID are all asymptomatic people.
Hmm.
Asymptomatic, close to 80-85% what the data says. And what we are going to deal with cardiac patients is among the 15% of the people who are likely to be sick and serious with the problem, among them 40 to probably 70-80%, that's what the data says, will have some cardiac involvement. So ultimately out of 100 people, we are likely to face 5 to 10 people with cardiac involvement. This is what we can arrive from it. See, most of the people coming with an acute injury, that is acute condition syndrome, either it could be due to ST elevation MI or non-ST elevation MI, they may have, they may be in a window period, completely asymptomatic. Whatever the precaution we are trying to do, where we are having a screening test with a sensitivity of 60 to 70%, even if that all our precautions, if you are going to admit the patient, what is the possibility that doing a conservative management is itself a risk? First point. Second point, after all the investigations and after all these things, okay, if the patient turns out to be positive, what are the things we need to do?
Sir, I'll ask the first answer the first question first. In fact, we had a discussion in another forum, and somebody told the same point. He said, "Doctor, if I do a primary PCI, I send the home in 40 patient home in 48 hours. So I am reducing the risk to the hospital people. But if I do manage them medically, I'll keep them in hospital for 4 days, 5 days. So by that, say 2 days or 3 days in ICU. So by that, I'm exposing a bigger number of people to the infection as compared to when I'm doing a primary PCA. This argument is a very valid argument, but there are two caveats to this whole argument. One is there is some suspicion that during a procedure, whether it is a cath lab procedure or a theater procedure or any surgical procedure done on COVID patient, leads to some degree of deterioration in the clinical condition of the patient. So, for example, patient has a borderline LV or something which is maybe precipitated by an intervention. So these guys tend to deteriorate faster if COVID is the underlying etiology. So that is one concern. So COVID patient, if you have inadvertently done a PTCA, the chance that patient may deteriorate during the PTCA is higher. That's one concern. Concern number two is when you are conservatively managing the patient, that time the chance of patient deteriorating is high. So I personally feel the policy that I would advise people is, if patient is a good candidate for thrombolytic therapy, I think the argument is very simple. All other patients, it is better to send two samples. One is the RT-PCR as well as the antibody test as soon as the patient comes into the hospital. So these two tests, if they are negative, it gives you some degree of guarantee. I'm not saying it is 100% guarantee, but some degree of assurance that this gentleman may be negative, especially somebody is RT-PCR negative. So in our institution, we are doing RT-PCR 2 times in a day, morning and night. So any sample that is received before 9 o'clock and another is before 4 o'clock. So what I am thinking like this is, all those patients, at least 4 to 6 hours, we are buying time. Just like in the previous days, we used to talk about drip and ship. So I'm taking this philosophy and telling test and then shift. So we are following a protocol. So same thing, what we do is at the hospital entry, we are taking a sample. And at the end of 4 hours, we get some report. So if the troponin, if the RT-PCR is negative, antibody is negative, I think you are giving some degree of safety to the concerned consultant and as well as the healthcare staff. And another thing which I have started doing is, now I am using more GP2B3 inhibitors more freely. So I am using the same old logic that we were using 20 years back. So whenever patient comes with ACS, give them some drug. If you are not thrombolizing, give them at least GP2B inhibitors. Basically, try to buy time. Try to buy time of 4 to 6 hours. And if you are able to manage that 4 to 6 hours, you are giving some degree of assurance to your staff that it is negative. And then at the end of 6 hours, if it is negative, I think you can go ahead with the procedure, provided everything else is correct in the picture.
Excellent. Sir, well said. So the point is well taken. See, we have got very clear, you have made it very clear that primary PCA is not going to be the rule of the day. So primary PCA, no. So the patient comes in, almost every patient should receive only thrombolytic therapy. There is no doubt about it, and most of them there is not going to be any controversy and discussion on it. But only thing, how we are going to handle the asymptomatic patient was the one thing which is there, which you rightly pointed out that doing a RT-PCR at admission, or if there is going to be a negativity, if what you want that second RT-PCR test, at what space you want to be done?
Our policy is very simple. First RT-PCR. The second RT-PCR actually has not much validity unless there is any reason to suspect. So what I have been advising my unit people is one RT-PCR on admission and an antibody test on admission. And
but antibody test is right now we don't have in our hospital.
No,
it is not recommended. So right now there is it's not available.
No, it's a very controversial thing. The Chinese kids are very bad. We'll leave that next discussion. What we have been doing on the 72 hours after admission, we are repeating the RT-PCR. So we are assuming that 2 RT-PCR 3 days apart gives us some degree of guarantee. Again, there is no 100% guarantee, but
okay, can I put it in this way, where the patient at admission gets a lysis, standard protocol, or if there is going to be non-estimation of my stabilization with or without glycoprotein 2B3 inhibitor. So this is what we are planning. Admission RT-PCR. After 48 to 72 hours, another RT-PCR. So if both are negative, or the patient has got recurrent post-MI angina or failure, without requiring intubation or likely to have sudden cardiac arrest or arrest during the procedure on the table, can we go ahead and do a PCA in this patient?
Yes,
is there any clear recommendation for you?
No, I would take it in a different way, sir. You have done all this thing. Still, I leave that option of intervention at a later date. What I may do is do an angiogram. See, at the end of it, the cath lab exposure is also important. So I may do an angiogram, and if I find out the anatomy is not critical, the anatomy is something which may benefit by a CABG later date. Again, those subset of patients, I would be very happily sending them home, because I want to reduce the risk for everybody, not only the patient, but our own people. Very selected patients, what I will think, okay, he has a proximal LAD 99%, RCA 99%. These are the selected group of patients where I will go ahead and do an intervention. So I've become so conservative that even for an angiogram, I think is a big leap forward. After that also, for example, we had some patients who underwent an angiogram in an adjoining institution. Patient has 70-80% disease in all the 3 vessels, no recurrent angina, no signs of heart failure. I spoke with our surgical team not willing for CABG at this phase, family not willing for CABG. So they came back and said they want PTCA to all the 3 vessels. So since the patient is hemodynamically stable, no chest pain, no breathlessness, no issues, EF is around 45%, I have scheduled their PTCA for May 5th. This is what I think is a safe option.
Excellent. See, that is basically we are trying to manage conservatively on most patients, and some of the patients which is discrete lesion and life-threatening and critical lesions are there, we are trying to address. And as you said earlier in your presentation, all the cath labs have laminar flow, and all the cath labs have only positive pressure, and there is not going to be negative pressure in our cath lab. Likelihood of having infection during the procedure and having a high viral load is always high. So the guidelines from our discussion is very clear. A small protocol where acute MI, we are going to lyse. After that, after possibly 1 or 2 COVID testing or possibly antibody testing, from there on, take the patient for an angiogram. There is going to be a critical disease which needs to be addressed very discreetly and quick intervention. We are going to go ahead, or it is going to be a triple SL disease. we are going to do recommend them for a medical management followed by a CABG at a later date, whatever the patient and the surgeon decide on. This makes things much more clear, I believe. I'll just move to Dr. Anand Kumar. Sir, your presentation was also equally very good and it was very, very informative. So I can just ask few questions to you. Sir, you are very clear that the guidelines, ICMR guidelines at admission, we can have a paper of things which we need to ask, history of travel, history of dyspnea, history of fever and everything. See, the only thing is patient comes not the first time to your hospital. The patient may have landed in 2 or 3 hospitals before this and they have been sensitized by this question. So they want to get treatment. They come to you with this question. Having known this questionnaire, they start coming with a denial. Most of them denies the history at the first place. That is the problem here right now. Most of them deny because they have been sensitized by the question. They deny the travel history, everything. Now you are in trouble, whether you are having a COVID positive patient, high risk COVID positive patient with a dyspnea, with a ACS mimicking myocarditis, where it could be due to cytokine storm or it could be due to hypoxia, hemoglobinopathy, or the viral per se can cause myocarditis or acute coronary syndrome associated with it because of the inflammation as well as the pro-thrombotic state which is happening. So, if so many things are there, how you are going to manage this patient?
Sir, you are not audible, sir. Sir, please keep unmute, sir.
Yeah. Can you hear?
Yeah, that's
you are audible.
Yeah, thank you. Thank you. That's a nice question. I think in the onset, I will say that I am working in Lakeshore Hospital, Cochin. So we are following the guidelines by our state. That is our state government health department now following a app called Disha. So we follow that guidelines. So the in Ernakulam district, whenever a patient comes, only a few hospitals take the patients. Only about 20 hospitals in the district take suspected COVID patients. Our hospital also takes patients. So we have a routine screening. All the patients comes through a screening panel where you have this infrared temperature screening, and the paramedical staff will check the questionnaire. And if the questionnaire is all negative, but still the patient has patient is not having any travel, no relatives in the house who had a travel, no contact with a corona patient, and not visited any corona positive hospital, then only the patient is comes to our center, comes to our OP or casualty or the ward. All the other patients are sent to the district COVID treatment hospital, which is the Ernakulam Medical College, which treats only COVID patient, nothing else. So theoretically, what you asked, sir, that probability was a little high in the initial days of lockdown, but now anyway, now we have nearly more than 1 month of lockdown, so the chances of a positive patient from abroad has become very, very less. This will become a real possibility when the lockdown is over and when you get more of international flight patients back in our hospital. So if the patient denies, it's very difficult, but all the dyspnea patients, when it comes to cardiology, either directly or through a medicine and as a reference to cardiology, our standard protocol is to do all tests and rule out CAD, coronary artery disease, ACS, using troponins, and also heart failure using echo and BNP. So now, in addition, we have also started doing these ferritin levels, and all these patients are seen by our COVID panel that is headed by our chief pulmonologist, our pulmonology team. So if the patient denies, some of the patients we may ultimately we will be able to get. When I have seen some patients who have denied this to the front office staff or nurses, but when we take history, he comes up with the truth that he was advised quarantine for 28 days, but he's actually completed only 15 days like that. But most of the cases we'll be able to find out. And as we said, we can only manage, like if there is a, consider all patients as COVID unless proved otherwise.
Sir, excellent. Sir. So this is what the bottom line is very clear. Consider all patients as COVID unless proved otherwise. That is fine. Sir, the other investigation which I saw in your slide is a lot of things like serum ferritin, LDH, D-dimer, and all these things can show a lot of light. But most of the things will be positive or will be abnormal only when the disease is more advanced. What is, yeah, very basically for you and Dr. Manohar as well, what is the role of simple total count, your leukopenia, lymphopenia, monocytosis? Can we track this and make a conclusion? Because asymptomatic patients, the first thing is your any viral infection. You may have leukopenia, and sometimes here we are seeing more in lymphopenia and monocytosis. Is it going to be useful in our practice? Because the rest of the tests are all in the advanced stage where this is a florid infection. Is it your baseline chest X-ray or a CT scan screening or a total count? Can it give some light in managing the patient?
I would answer this question, sir. The thing is very simple. Any viral picture of lymphocytosis, lymphopenia, monocytosis, these are all not very strong indicators. If I don't have any support system, the easiest thing for me to do is a CT chest. I think that is the easiest thing we can do in most of the places. If you look at blood markers, I think the one with the maximum validity is CRP. Most of these patients have CRP in a very high range. So CRP, chest X-ray would be the thing. I think most people can do it. The other clues are obviously not very feasible in smaller centers. Is looking at ferritin levels or looking at IL-6 and all. But I personally think in small setups, the easiest thing to do is the CT chest and CRP. I think that two things may give us some clues more than other things.
Okay, can we add CT just as part of the screening protocol on second or third day of
Yes, sir.
admission?
Yes,
so
sir.
that it becomes a screening tool before taking for a PCA?
Yes, sir, that's a good idea, sir, because many of the people whom was picked up, for example, I don't want, since this is a interaction, the neurosurgeon who passed away recently was asymptomatic till somebody sent him for a CT chest. So CT chest was so typical. Then only he walked and got admitted. It's not that he was in florid respiratory symptoms and all. He operated on a patient who was COVID positive, and after that, when they did a chest X-ray, there was something suspicious. They did a chest CT, and CT showed things before he clinically deteriorated. So I think CT can be included in the ruling out platform at least.
Excellent, sir. Thank you very much for that. Yeah, Dr. Kunal, you have any questions from other people?
Sir, first of all, definitely it was a very fantastic and very in-depth and live interaction. So,
You are not audible. Only a background sound.
it's okay, sir?
Yeah.
Yeah. So I think, sir, it's a very good interaction and very good presentation. Some of the question is already answered by you. For example, that how to differentiate the dyspnea and shortness of breath in the current scenario, whether it's a cardiac patient or COVID-19. But sir, regarding what we are discussing more on fibrinolysis in STEMI patient, so one of the doctor from Pondicherry, Dr. Dev Kumar, was asked that how to manage the patient with chest pain at physician level, because right now the transportation is not available. The patient has some chest pain and it comes to the nearby, emergency department where only the physician and the MD who are doing the cardio practice are doing. So is it advisable in that case that a doctor can give the fibrinolytic to that patient and then he can evaluate further whether it's a COVID suspect or COVID positive? He is not aware about that.
Kunal, the answer is very simple. They should not transport the patient. Answer is very simple. Don't transport the patient. Take an ECG, share it with all of us. All of us are jobless now. So we are very much keen to report our ECGs to people. So share the ECG with us, discuss with us, and then thrombolize in their center. So the answer is loud and clear. Don't shift. Don't manage at your place. In fact, I tell all my patients the same thing. When patients call up and say that we want to come and see, I tell them very simple. I am at high risk of being COVID positive, so better don't come. So
that
that's
is
the
okay.
easiest answer I tell all my patients, because I say we deal with patients. There is a high probability I'm COVID positive, so please don't come. So I tell them, come back, whatever is the video call, WhatsApp call, whatever is there, please come. But don't come, because we don't want to make you join our group. That's how I discourage people from traveling.
Okay. All right.
Kunal, again, not audible.
Host is just now I am unmuted. Okay, fine. Sir, would you like to add anything, sir? Dr. Anand Kumar or Dr. Arvind Kumar, or I will go for the next question.
I think it's time up for us, I believe. It's 6 o'clock. Okay, you have any other discussion to go on?
Yeah, just last question, sir. Here I would like to add that one thing is that uh, what could be the role of hydroxychloroquine in these cases, whether we can give it or not, when patient having a history of already something cardiovascular disease. This is one of the doctor from Nagarcoil, Dr. G. Nagaswamy has asked this question.
So I'll answer this question, but it is my guess will be as good as the his guess only, the person who asked the question also. But hydroxychloroquine is probably effective. It is a doubtful benefit. We can only say doubtful benefit, and whatever benefit probably is there when it is given early in the course of the illness, because it is supposed to have antiviral effect only. So if the patient is in florid, late heart failure type situation, hydroxychloroquine may not be very effective. And if you want to give the patient hydroxychloroquine because no other drug is possibly maybe effective, you can definitely give with monitoring the QTC. If the QTC is prolonged as more than 480 milliseconds or so, then I will not be very confident of giving hydroxychloroquine. Otherwise, I will give hydroxychloroquine. Probably as a theoretical discussion, the torsilsumab, the interleukin monoclonal antibodies against cytokines, that if available will be probably theoretically at least that will be the drug of choice, and in this category, that is the late phase of myocarditis.
Okay,
We are also awaiting further trials and all in that.
great.
Dr.
So,
Manohar, anything to add?
sir, you are not
Uh,
audible, sir.
I
Yeah.
personally agree that hydroxychloroquine in treatment is not great, but I think
Okay.
there is some role of hydroxychloroquine in prophylaxis. So I personally feel healthcare workers at least can take it, because it's not a very toxic drug for people like us. So at least we should be taking it. For patients, as sir pointed out, very important, early in disease, it has shown to reduce the complication. If you start when patient is crashing, I think it is no role. Only tocilizumab has some role. So two things, definitely in prophylaxis. Number two, early in disease. So these two scenarios it will be there. And regarding this QT prolongation, I personally believe we can manage it, because we have managed chloroquine given by primary healthcare workers for so many years. So I think we can manage it, unless somebody has structural heart disease of a severe nature with a significant underlying QT prolongation. I think I would be confident of giving hydroxychloroquine to most of my cardiac patients, except people on amiodarone, probably.
Okay, great. So, just last question to our moderator, sir. I think we have discussed many things regarding the cardiac complications and in COVID-19 and all. So, there is one question from Dr. S. Kumar. He is asking that in future, after just COVID-19, suppose era is going to decline after some time, then in future, what we can expect other cardiovascular complication in our routine practice because of this viral infection?
Is this the,
You are asking late effects of COVID, late
Yeah,
cardiovascular effects of COVID.
late effects of COVID-19 in specific cardiovascular related. Is there any,
Okay.
sir? It's a very early to answer on this.
Very early to answer, because even the cardiovascular, acute cardiovascular effects itself, we are debating so much to find out the cause and management. So late cardiovascular effects of COVID is anybody's guess. Yeah, but for the time being, I will be concentrating on, I'll just want to say one thing, that the treatment of this COVID patient is going to be not a 1 week affair or a 1-2 week affair. It may be gone for 1 or 2 months, and then only maybe you will say that, okay, he's okay. Because in this previous slides, I have shown the real life case. You can have an asymptomatic patient, then you can have just an upper respiratory infection sort of picture, or later you can have a pneumonia and you can die of that. There are now coming hundreds of cases where we have successfully treated pneumonia with the ventilator. Patient has been extubated and then going into the cardiovascular phase and dying with severe LV dysfunction, with very dismal endpoint. And the case I shared, which appeared in the Chinese journal, he survived the cardiac phase also, and later died of the secondary sepsis and secondary bacterial infection and sepsis. So unless I will say that we are seeing now in Kerala, we are seeing patients who became positive after 38 days of quarantine. So we are getting more and more strange experiences with this virus. So I think rather than, I will not say anything about the long-term cardiac complications of COVID, but I will say that you keep on these patients on a follow-up and monitoring for at least 2 months before saying that, okay, you will not die of COVID.
Okay, great.
Thank you.
Yes, sir.
Thank you.
Okay, so Dr.
We will
Manohar,
pray-
would you like to say something?
We will all pray that we are together and we meet in person.
Thank you.
Definitely we will meet. Definitely we'll meet, and I think that it's a very good discussion, I think, on that. So before closing, sir, Dr. Arvind Kumar, sir, would you like to add anything, or should I close the session?
We are happy with the discussion, with the excellent feedings from Dr. Manohar and Dr. Anand Kumar.
Thank you, sir. Thank you, sir.
Okay, great. So just, sir, in my closing, I just would like to share that this telecast was broadcasted to only 2 states of the India. One is the Kerala and one is Tamil Nadu. And we have exact figure number. It's around 748 doctors has enrolled in this particular webcast. That includes our physician, diabetologist, cardiologist, and everywhere. So I think definitely they must be privileged with such kind of in-depth and very scientific discussion on these particular aspects of acute COVID-19 and the ACS and the breathlessness management as well. So so with this, sir, here I would like to thank our all faculties, Dr. Arvind Kumar, who has moderated very well this both the sessions, and both the speaker, Dr. P. Manohar and Dr. Anand Kumar. I think we have already heard many times, and this is a not exact cardiac topic, but it is related to COVID and related to some part of the cardiac. But the way you have managed is very well, and definitely it will be helpful for our all the audience who has attended this webinar. So on behalf of Zydus Cardiva team, I am thankful to all 3 faculties, and thanks to all the audience who have given the valuable time to join this webinar and make it successful. Thank you, sir.
Thank you. Thank you.
Stay healthy. Bye.